Hello, Omar. My name's Ben. Do you mind if I examine you?
No.
First, make a thorough inspection. Look for deformity. The patient should be comfortable and adequately exposed. Get good views from in front and behind of the patient and including the axilla. The abnormal contour of posterior dislocation is best seen from above. Is there evidence of swelling or muscle wasting? And consider the size and position of the scapula.
Can I ask you to stand up and lean against the wall for me, please?
Asking the patient to press against a wall can elicit winging of the scapula, a sign of paralysis of the nerve to serratus anterior.
Remain standing.
Palpate along the clavicle from the sternoclavicular joint to the acromioclavicular joint.
Let me know if it's uncomfortable at any stage.
Clavicular fractures and acromioclavicular joint injuries are accompanied by deformity and local tenderness. Also palpate the acromion, the coracoid process, and the scapular spine. Palpate for tenderness of the biceps tendon in the bicipital groove and the supraspinatus tendon.
Hyperextend the shoulder to bring the supraspinatus tendon anteriorly out from under the acromion.
The next two screening tests of shoulder movement are best seen from behind.
Can you put both of your hands behind your head, please?
This tests abduction and external rotation.
And now reach behind your back and reach up as far as you can between your shoulder blades with your hands.
Testing internal rotation. Proceed with full examination of the shoulder if you have found pain, swelling, or limitation of these movements.
Now can you bring your shoulder forward like that?
Ask the patient to demonstrate range of motion
As
in
high as it will
flexion
go. And back down to your side. And back up the way, like that.
and then extension and abduction observed from behind.
And back down to your side. This time, can you bring your arm out to the side as far as it will go?
During abduction, palpate the inferior pole of the scapula to determine the degree and
back
smoothness of the scapular component of this motion. Measure shoulder rotation with the arm adducted and the elbow flexed.
Now with your arm by your side like that, can you move it out to the side?
External rotation.
And now reach behind your back, and again reach up as high as you can with your thumb.
Internal rotation is expressed as the highest spinous process that the patient can reach with the thumb.
Now Omar, can you bring your arms up to the side like that for me? Hold them there and don't let me push them down.
Assess the ability of deltoid to abduct against resistance, comparing left with right.
Also check the patient's ability to initiate abduction against resistance with the arm down at the side.
I want you now to push out against my hand, Omar.
Weakness or pain in initial abduction suggests a rotator cuff problem. The next test is for subacromial impingement.
I'm now going to bring your arm all the way out to the side and up to your ear.
After passive abduction,
And now bring it back down slowly.
the painful arc occurs on controlled adduction.
Is it painful at any stage?
No.
In impingement, pain would be reported between 60 and 120 degrees of abduction.
Now, Omar, can you reach again around behind your back? With your hand now, I want you to push out against my hand.
In this position, subscapularis is isolated as the only muscle contributing to internal rotation.
Relax.
Next, we test the external rotators, infraspinatus and teres minor, with the arm adducted.
Just flex your elbow up and bring your arm out. Now push out against my hand as hard as you can.
With the shoulder adducted and in 30 degrees of flexion, the contribution of deltoid is limited.
Thank you very much.